So my name is Kim Davis. I work at Yale, and I'd like to thank the SAGES Program Committee for the opportunity to speak today. The topic that I was assigned was emergency general surgery in the 80 to 90-year-old patient. And while as a resident I thought that I would never actually have to think about something like this is increasingly common as our patients become older. So I have no financial disclosures. I will, however, point your attention to the picture and cliff jumping. Cliff jumping always seems like a really good idea at the top of the cliff. About halfway down, you wonder what you're doing, and right before you hit the water, you wonder what you're going to hit, other than water. And I like this analogy because it reminds me that we as surgeons are very comfortable in deciding what surgical interventions we are going to be able to apply to most of our patient population. But taking care of the very elderly is a lot like cliff jumping. So what I'd like you to take away from this talk is two things, and I stole this liberally from Ron Mayer, the current president of the American College of Surgeons. The first is that our patients, particularly our elderly patients, are acutely ill, and they are at risk of dying. And the second thing is they really need our help. They don't know what they don't know, and we really need to have an informed and educated discussion with them about the risks and benefits of surgery, including that we may make them worse than they are now. So my objectives are to look at perioperative assessment, including cognitive deficits, frailty, and nutritional status to help you with this decision, to give you some background on outcomes, and to reinforce the role of palliative care in surgery in the octogenarians and nonagenarians. If you look at this chart, you can see that fully 50% of patients over the age of 90 are demented. Thank God it's not over 50. And a quarter of patients over 85 are demented. Demented patients do not do well after surgery. So as your patients get older, you really need to do an assessment of their underlying mental status. This is a look at dementia and surgical outcomes, putting it into our perspective. And patients who are clinically demented have a 1.5% chance of dying within 30 days of surgery. They also have a higher rate of complications just because of their dementia, and that's about a twofold increase, including acute renal failure, but particularly pneumonia and sepsis. Stroke and UTI are also more common in the demented patient. This is an otherwise healthy demented patient. The American Society of Geriatrics just updated their Beers criteria for potentially inappropriate medications for patients or for older patients, so that you minimize or mitigate against the development of delirium in your patients in the perioperative setting. We are strongly encouraged to avoid anticholinergics, including Benadryl, antipsychotics, benzos, corticosteroids, H2 blockers, and narcotics, which basically leaves us with Tylenol, lidocaine, and inventive methods of providing pain control in the perioperative phase. And again, you want to enhance, if you're trying to take care of a patient who is already demented or has the potential to develop perioperative delirium, you need to make sure that they are frequently reoriented. The lights need to be on during the day and off at night. They need to be fed. They need to be spoken to, and they need to be up and out of bed and walking. And I don't know about how well we do that in your hospitals, but I know in my hospital it's very difficult to encourage people to get the elderly patients out of bed because they require more assistance. The other thing I'd like to bring to your attention is the concept of frailty, and whether you look at somebody and say, oh my God, that person's frail, or you use measures of sarcopenia or other measures that are out there as a frailty measure. Frailty increases the risk of complications around surgery. And one of the easiest things to say to your patients is, hey, how often do you fall down? Now, I get really offended when I go and see my primary care doctor and I'm asked if I've fallen down in the last couple of months. But once you're over my age, double nickels, I'm getting there, you really have to ask this question, how often do you fall down? Because it's really a marker of frailty. And if you look at patients who undergo colorectal surgery, they are more likely to have one or more complications, an institutional discharge, and readmission within 30 days if they fall down in the preoperative period. The other thing I'd like to point your attention to is the nutritional status of our patient population. And as you can see, those people who are out in the community, about 60% of them are well-nourished, but that's as good as it gets. And that means in the community, 40% of patients who are older than a certain age are malnourished and therefore have impaired wound healing, impaired ability to fight infection, et cetera. And when you get to patients who come to the operating room of a nursing home, that number falls to 30% of people who are well-nourished. In the hospital, if you get consulted for the free air in the MICU, that malnourished patient is about 85 to 90% of your patient population, and it gets worse. And when you look at the number of operations that are occurring as we get older, you can see that there is an increasing frequency of major surgical intervention in the elderly population, approaching 7.3% of patients over the age of 90. Our patients who undergo emergency laparotomy are very ill. 50% of them have an underlying malignancy. A third of them have congestive heart failure or a self-reported health of poor or fair. And about 20% have renal failure, dementia, or dependence for activities of daily living, i.e. somebody has to get them out of bed, somebody has to help them with their bowel and bladder function, et cetera. So if we look at what defines a serious illness, it is something that reduces quality of life, it is associated with mortality, and it implies that the patient will become a burden to those people taking care of them, and nobody who has a brain wants to be a burden to the people that are taking care of them. And I direct you to this comment by Ben Eisman, who is a past president of the American College of Surgeons, and he gave a discussion on surgery in the elderly in 1985. And I thought that this was a very important statement to bring to this audience. Older people make decisions with a different database and different value judgments, such as palliation and quality of life. There are a lot of things that are worse than death to an elderly patient. As you look at the incidence of complications starting at the age of 60, it's about 33%. It climbs up over 60% by the time you get up to the age of 90, even with best outcomes from surgery. When you look at mortality and age associated with general surgical operations, there's a sharp uptick after the age of 70. And when you look at laparotomy, mortality rates after laparotomy for older adults, the rate drops off dramatically. This is 65 to 74, 75 to 84, and again, greater than 85, with an overall mortality rate of about 50% within 1 year of surgery. So you have to ask yourself why you're offering the patient surgery. Even in the best of hands, functional recovery after surgery in octogenarians and nonagenarians is not good, and at 6 months after surgery, fully 20% have not achieved their pre-morbid level of functioning. So your frailty impacts outcomes. The diagram on the left is frail versus not frail versus overpopulation. And if you are frail, you're less likely to survive. And the graph on the right demonstrates that it's not the big operations that we're talking about. As a matter of fact, frailty markedly impacts the outcome after appendectomy, and that is laparoscopic appendectomy. So an older person, frail versus non-frail, may have the same outcomes after a truly major operation, but they are much more likely than their non-frail colleagues to do well after appendectomy, cholecystectomy, or lysis of adhesions. So what our patients, what we talk about is we like to inform our patients and give them surgical options. We are not very good at addressing what the patient wants to hear, which is understanding outcomes, understanding patient goals, and providing support for decisions that may be difficult, particularly for the younger family members of your elderly patients. There is a huge burden of palliative care needs in the emergency general surgery population, particularly the elderly emergency general surgery population. If a patient is in the bed or in the chair more than 50% of the time during the day, and that's me post-call, they should be considered for a palliative care need. If they have an advanced level of organ dysfunction, poor nutrition, or an underlying malignancy, they should be considered for a palliative care consult. If you do not provide a palliative care consult, again, overall in the elderly population with indications for palliative care consultation, 40% of them will die within 1 year of surgery. And about 63% of the elderly population has one or more palliative care needs at the time of presentation. So I think that if you don't have a framework about how to discuss how aggressive the family and the patient want to be, and you don't have that conversation on the front end, it's very difficult to have that conversation on the back end. We all in medicine have the snowball effect. We try something, it doesn't work. We try something more aggressive, it doesn't work. We try something even more aggressive, it doesn't work, and then we throw the Hail Mary. And once we throw the Hail Mary, we realize that we probably shouldn't have started the snowball down the hill in the first place. So my golden rule is do unto others as you would want to have done unto you. And I would say that dying is really the only thing to be sad about. Living unhappily is something that is totally different. So as we look at the three pillars of acute care surgery, trauma, emergency general surgery, and surgical critical care, I urge all of you who take care of emergency surgery patients who do worse than general surgical patients to incorporate surgical palliative care into your practice, particularly for those patients who are nonagenarians and octogenarians. And I'd really like to thank Ron Mayer on the left, the current president of the American College of Surgeons, and an outstanding advocate for the care of our patients. And then Ronnie Rosenthal on the right, one of my colleagues, fortunately, and the person who is designing the geriatric component of the American College of Surgeons education. Again, thank you very much. It's been a pleasure to speak.